Hello, this is Matthew Pifer. I'm an orthopedic surgeon practicing out of Santa Barbara, and I'm presenting a interesting and complex case today, which is an anatomic total shoulder that I use the convertible glenoid for a type C. This patient was a 50-year-old right-hand dominant male that was an IT director of the local university in Santa Barbara. He was referred to me from another orthopedic surgeon in town for treatment of severe arthritis of his shoulder. He has difficulty sleeping, he's had chronic pain and extreme limitations of his movement. He has a past medical history of prior instability at a very young age. He's had multiple surgeries. His last surgery was a clean out of the shoulder back in 2016, approximately 3 years ago. On physical exam, he was very limited with his range of motion. His external rotation was only 10 and his forward flexion was a 90. This was the limits of passive, so he was very stiff and he had extreme crepitance with motion of his shoulder. Here's his initial x-rays in the office. As you can see from the AP, he has severe glenohumeral osteoarthritis, inferior osteophyte. And then when you look at that axillary, you can get a really good feel of the dysplasia of the posterior aspect of his glenoid. So a Walsh glenoid type C, which is anytime you have more than 25 degrees of retroversion. It's hard to exactly approximate it on the x-rays. I wanted to see what his cuff looked like for preoperative planning. Fortunately for him, the rotator cuff was intact. He had a little bit of interstitial, maybe some tearing or inflammation, but for the most part it looked good. These are just more pictures of the MRI showing no muscle atrophy or evidence of cuff pathology with his cuff. On CT scan that was ordered up, it gave me a little bit better feel for the vault. This was also part of my preoperative planning to upload the CT scan into VIP. His diagnosis is an advanced glenohumeral osteoarthritis with a Walsh grade C glenoid. He's a 50-year-old guy, so he's very young, but he has an intact rotator cuff. So I really want to know, when I'm planning my surgery for him, how bad is this glenoid really? What is the exact retroversion? Also, how much vault do I have and where is his vault and what do I have to work with? So my initial step is to send out the CT for VIP planning and evaluation. So that's the first thing I did. I got my VIP numbers back, and before I looked at the pictures, I saw he had a retroversion of 35.5. He also has an inclination of almost 16 as well, and this obviously is something that we're going to have to deal with, and VIP is going to help me. So you can see a good representation right now of his VIP. You can get a feel for where I placed my implant, how bad the retroversion is, and just exactly where I have to get it into where his vault is to have the best placement for this glenoid. The implants I chose for this case were the Arthrex Universal Glenoid. I have multiple reasons for that, which we'll get into. I got the version to -9, so I tried to get the inclination down as low as I could go, and 4 was it. So it's just something to think about when I'm planning future surgeries. So why did I choose the convertible glenoid? Well, I did this because of his age. He's 50 years old. He's a young guy. We're already thinking that I'm probably gonna have to convert this at some point in his life. The convertible glenoid makes this a lot easier. Also, in addition, the convertible glenoid allows me to lateralize the joint line very easy. There's 2 sizes of the poly, and it actually builds it up naturally a little more, so it's a good system for medialized joints. He also has the complex C-type glenoid. This is a lot of retroversion. It's much easier to handle with this type of base plate than a poly glenoid or even a poly augment. He also had really good glenoid vault, fortunately, even with his bad C-type glenoid, and this is great for fixing the large centralized post. As far as surgery goes, he got this anatomic total shoulder. I did a biceps tenodesis as well. For my components, I used the apex humeral stem. It was a size 9, and he had a 48mm head. For the glenoid, as we discussed, I used the convertible glenoid. It was a size medium, and it had the poly insert. The subscap repair, I did a sharp peel. I do not like to use electrocautery or Bovie to peel off my subscap, so I use a scalpel. And then I did the repair with the apex subscap repair technique. I really like this technique for repairing my subscaps. So post-operative, he went home the day of surgery. He had a sling on for 4 weeks. I gave him aspirin for DVD prophylaxis. I said it's okay to do your pendulum exercises and have active range of motion of his hands and his wrist. And I was going to start his therapy like I normally do 2 weeks after the visit. So he comes in 2 weeks out, he's doing great. He's saying, "Doc, I'm off my pain medication already." On physical exam, it's pretty basic. His incision looked good. I gave him a PT script and I said, "Come back and see me in 4 weeks." X-rays looked good. This is pretty much what it looks like when the implant's in. You can see how the glenoid is placed and no loosening, good alignment. 6 weeks is very similar. At that point, he came in, he was 2 weeks out of his sling, he was feeling really well. He started therapy already. I got his active range of motion up to 90. This was assisted. And his external rotation, I left alone. I typically don't test it until later. I just don't want to mess with that subscap. I told him it's okay to start moving it though. So now 3 months out, he comes in, he's feeling great. He has much less pain before surgery. He's telling me that he's moving his arm more than he's done it in years because of his range of motion. He was doing things he was not able to do before surgery, as far as getting to the top shelves when he's grabbing plates and dishes. He's still working with therapy. He's feeling like he's getting stronger. His muscles have not moved with this range of motion in a while, so it's going to take a while. On physical exam, he's getting up to 150 forward flexion. His abduction is 90, his external rotation is 70 with a good subscap repair, and he's internally rotating up to his lumbar spine. Just to contrast, already he has 60 degrees more of forward flexion than he has been living with his life before the surgery. Abduction is a little bit improved, and his external rotation is greatly improved. Here's the x-rays. Once again, it's a well-seated, well-placed implant. Looks good, no failures, no issues. And then this is a nice axillary view, kind of seeing the placement. So in conclusion, this was a very successful surgery that I think was only able to be done this way because of the new convertible glenoid system with this complex type C glenoid. The VIP really helps me on these cases. I'm able to plan it out, place that pin directly where it needs to be every time, and then the complex glenoid was handled by the convertible glenoid very well. So in conclusion, the convertible glenoid is a powerful tool for these total shoulder cases with difficult glenoid morphology.